Oh, hey, Chris.
Hey Chuck, how are you?
I'm good. I'm good. It's new for us recording on a Saturday afternoon, the day before the pod drops.
Right, this is right up to the wire. Usually we kind of get things tucked away early on, but we wanted to give people something super fresh.
Yeah, absolutely. I feel like I hadn't seen you in person in a while either.
Well, that's because you haven't. So we haven't seen each other in a long time. It's been a while. So you've been globetrotting, doing quite a bit of work overseas, is that right?
Yeah, we should talk about that. We should talk about your travels. And yeah, I think you and I have talked about what we could accomplish in this pod. Maybe we have a couple interesting cases we can go through that are new and different for at least for discussion.
Yeah, no, I think we have some great cases to discuss. I'd love to hear about what you've been doing, and I just came back from somewhere, about to go somewhere else. So yeah, it's really interesting. The I don't know how much, maybe not where you just went, but the podcast has a very far reach, and there are a lot of people that really enjoy it, and I really appreciate when people come up and say how much they enjoy the podcast and what they've learned, and why it helps. So I am a big, as I've learned over the years, my love language I like to receive is words of affirmation. So if you're out there, keep telling us how much you love it.
There is so much truth to that because we need that affirmation because I think we're both at least somewhat busy and it's hard to keep the pod going, but I think it is a passion for both of us and the little things matter. And for example, the way podcast listens are calculated are now different than they were 6 months ago. And even that type of stuff kind of makes you second guess the impact that we're having. But when someone speaks to the impact, it says everything.
Right, absolutely. I mean, literally every place that we go, I'm sure you hear it too. Somebody's like, I'm sure you hear this all the time, but we love the podcast. And it really does help to know that we're reaching people. So, we do like to hear from folks. So send us your questions, your comments. We've had some really great episodes come from people emailing and writing in. And yeah, you're right. I mean, I think the metrics are changing, and maybe we should change to meet the metrics, but I think we do what we love, and we love what we do. And it is really honestly super fun once we find the time to do it.
Yep, exactly right. So let's start. I'd love to hear first about your recent travels and your upcoming travels. Um, no food related travels, hopefully just work related travels.
I did sneak some food in, but no, I had the honor of being invited to the UT Houston orthopedic residency as their visiting professor. It was super fun. I did not realize how big that department has become, and really how much they've changed since when I was a medical student looking at that program. I looked at the roster and saw just how many, like, first off, how big it is in their reach, and just like every academic medical center and department looking to expand their reach through through outpatient surgery centers and satellites, et cetera. But then just so many people that I recognized along the way. So I had a great time. I shared some stories about how I met my wife in Houston, and when we were both 17 years old, and how we got married in Houston. I spent a year in Houston, enjoyed going to Houston Rockets games in the Yao Ming, Shane Battier era. McGrady was there too. So it was super fun to see everybody, and gave a couple of talks. Got to have a really great dinner with some of the residents, one of whom just matched into hand. So shout out to Shrina going to Philly for her hand fellowship, and we got to hang out with Hayden, who's going to be applying next year. So it was really fun. Saw some friends, James Saucedo, Dean Smith. It was great. It's always fun to kind of share how we approach things at WashU, and give a case presentation and try to keep things spicy for the residents during their rounds.
Two questions. I know you've missed that. Two questions. First, were you there for the 100-mile-an-hour winds and this crazy storm I read about?
So I got out, I guess, a few hours before. The reason that I heard about it is that my friend James Saucedo, who I met when I was way back when doing research down there, he's on faculty there now, and he had texted both me and Dan Osei about something, and Dan was like, "Hey, how the pictures look crazy down there." I was like, "What happened? I didn't see any of this." So I learned about the weather afterwards, after I got back home to St. Louis.
Yeah, something. And then it goes from there's still power outages, and yet it's 100 degrees there, so it's not a great time for Houston. Houston's had some rough go with the weather.
Yeah, they had that crazy thing where all the toilets froze a few years ago. I mean, it's insane, but it's got a soft spot in my heart. I had a really good time, so I really wanted to thank that program at UT Houston for inviting me out. They have a really great energy down there, and I really enjoyed it.
And what aspect, forgive me if I'm wrong, what aspect of nerve surgery did you discuss?
I have a fun talk that I like to give about common issues, or you could say complications after orthopedic surgeries, common orthopedic surgeries. I feel like that's a if I was coming in and giving a grand rounds, I wanted to find something that was applicable to a lot of people, not just the hand surgeons out there. So there was all sorts of cases. There was peds, shoulder arthroplasty, sports arthroscopy, hip and knee arthroplasty. So all the issues that can come up, which I love about nerve and being a hand surgeon, is that you kind of get to go anywhere and do everything. So that was a good talk, and I gave another talk about controversies in ulnar nerve management, both for compressive neuropathy and for trauma. So that great case discussions, and they presented some very interesting cases, and one of which was actually a case from one of our former residents, Erica Giles, who is now a tumor attending down there. So it was really fun.
Ah, sounds great. And where are you off to next? Are you stopping to see a few patients in St. Louis, or are you just heading out again?
Oh, I had a clinic yesterday. It was it was a banger, as they say. It was busy. I was doing the solo clinic life, and it was intense. But it was good. I saw a lot of patients, got a lot of good follow up. I had a good time, and then working this week, and then I'm heading to Singapore.
Oh, that's right. Now, this is part work, part family?
Yeah, so the first half is work. I was invited by the group out there. Schumann, our friend, and a couple other folks invited me to do a research seminar with none other than famous hand surgeon Kevin Chung. So we're doing a 2-day research seminar. They are definitely getting their bang for their buck. I'm giving, I think, 3 or 4 talks and having to, kind of workshop and mentor some people, and it's going to be exciting. It's going to be fun. I'm sure I'll be doing the majority of my work on the plane on the way there.
Yeah, yeah. Oh, that's great. I know you guys will have a good time. And is the family just staying in the Singapore specific area? Or you guys
Yeah,
traveling
so
Southeast
just
Asia?
just in Singapore, that's more than enough for us, and the kids are gonna have a good time. We've got some family out in Malaysia, so they'll see them, and yeah, it's gonna be a whirlwind trip. We're looking forward to it. Hopefully all the flights go okay, and so we'll have fun. But
Awesome.
before I want to hear about your recent trip, and we've got those cases to get to. But before we do that, we should probably give our shout out to our friends at Practice Link.
Absolutely. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/theupperhand.
Yeah, so just got back from a mission trip a week or so ago. Slowly recovering. I have to say it was great in every way that we would hope. It was also exhausting. Um, I work with a group that is called the World Pediatric Project, which has recently renamed itself World Pediatrics for a broader appeal. It is far from just orthopedic surgery. We focus on the Eastern Caribbean and Central America, but do have some relationships outside those two regions. And so I'm involved in the board here in St. Louis, and it's a big and growing organization with multiple hubs: Atlanta, Richmond, Southern California, Miami to become a hub. And so it's great. It's great. And Lindley Wall and I sort of divide up the hand and upper extremity work in the Eastern Caribbean and typically make a trip about once a year. Um, and so this was our trip.
So that's amazing. I've heard from you and Lindley about those trips, and our fellows have really enjoyed participating in those trips. It's really kind of you and generous of you to bring them and have them see the work that you're doing, participate in it, and contribute. I know they really appreciate that. I think it's great that you've developed this system where it's not just a kind of drop in and do your work and then leave. I know a lot of work goes into it beforehand. Can you talk about how you've set up the system? I know that you and Lindley go separately, and that's very intentional. And there's a lot of prep work that goes on, while you're not there in the Eastern Caribbean.
Yeah, well said. So the way we have done it is that, the group we work with has boots on the ground on in all of the Eastern Caribbean, multiple different islands. And, we think about, I was in St. Lucia, but we think about St. Lucia, we think beautiful beaches and fancy resorts, and that is true. but that's, 2% of the island, and the rest of the island, while there certainly are healthcare services, what we do is not represented on the island or is not accessible. And so this trip actually, I think, required more preparation in a good way than others. And I say that because I did 3 telehealth clinics with different island populations: St. Kitts, Dominica, St. Vincent, and really had my surgical list pretty prepared before we ever got there. And what we do, and then we have follow-up as well. So it's not just the glamour of fly in, fly out, because that is not the right way to do things. And so we arrived there. We had travel issues, but we arrived there late Saturday night, clinic all day Sunday, and then we operated 4 days, took care of 20 kids, and it was great. The one thing that I would like to be different, but it is what it is. These islands are not conducive to a significant amount of orthopedic surgery education, simply because there are not the orthopedic surgeons that are either interested or available to learn in these areas. And so that differentiates this in a negative way, I would say. Anesthesia-wise, there was lots of people interested in learning about the blocks Ahalia Kadali was doing, and the processes, but not the orthopedic education. So that's I guess I'd say a missed opportunity, but it's not really a missed opportunity because again, it's just not needed there.
Well, I think you're playing the hand that you're dealt, right? I mean, so if you were in a place where there were a lot of people that wanted to educate, I'm sure you would be educating. I think that's probably the differentiator between that and something like what Jim Chang's involved with is it Resurge, I think is
Yeah.
what they do. Yeah. So I mean, if there was an audience, I'm guarantee you would be teaching them how to assess and evaluate and treat these patients, but that's not what's available to you. So
Yeah, the I think Emily Zaldos, who came with us, will never do a pediatric hand surgery again in her life. I'm certain when she's in remarkable Peachtree Orthopedics in Atlanta next year. But I think she had a great time, and certainly I had a great time with her. The pathology is interesting, and I think it's relatively characteristic. Birth brachial plexus palsy, secondary manifestations of that, cerebral palsy, largely untreated, post-traumatic, whether that's burns or just trauma that doesn't heal well, and then a little congenital. It's actually, I think we've hit a lot of the congenital, and we bring some of the more serious congenital up to St. Louis, which is part of the program. But yeah, good mix of pathologies, and nice early results.
yeah, I heard that you saw one of our post-op brachial plexus free functioning gracilis patients.
Yeah.
I was like, I saw
So
the video. I was like, that's crazy.
Yeah, so it is crazy. So the story is, kind of a silent, maybe I think he's 18 now, silent, very quiet kid comes in and he has sort of a rope around his neck with his arm and like a makeshift sling. And he walked in, I'm like, "Hi, how you doing?" And he didn't really have much to say. And then I kind of sift through some materials and realized that he had come up to St. Louis and had a free functioning gracilis transfer. And he had been educated on therapy, and we tried to connect him with therapy in St. Lucia, and just hadn't really happened. But what was remarkable, and I haven't seen a lot of these patients in follow-up, what was remarkable is that he's doing incredibly well. Anti-gravity elbow flexion is really good, and I'm sorry, gravity eliminated elbow flexion is really good, and anti-gravity elbow flexion is excellent as well. So the therapist who came with us, Stacy Baker, who's amazing, spent some time with him on a couple of different days, and yeah, he's doing great.
Yeah, that's basically all of our free gracilis transfers for elbow flexion. They kind of do their own thing, no therapy. No, he's great. He's actually pretty early on. I don't remember the exact time, but he is exceeding expectations, which is remarkable. So thank you for seeing him, and I'm glad Stacy was there. She is a really a wizard with the therapy, which is so critical after that kind of surgery.
Yeah, I know that mission trips are, it's interesting. I had to remind our group that this is not going to be easy. Everything's not going to go according to plan. And in some respects, that's the appeal. You have to sort of think on your feet. You have to deal with situations where you don't have anything that you want. And the flow is not going to be good. We were ambitious in getting 20 surgeries done. We got them done. And the group we had was amazing. So we traveled with an anesthesiologist, an OR nurse, a therapist, and our hand fellow. And it was an amazingly good group and really great. But these are less than ideal situations. But that if you think about it the right way, that's part of the fun.
Well, yeah, of course, you want to avoid the medical tourism aspect, and I think that you and Dr. Wall and all of World Pediatrics have really done a great job as to provide really a service to that community and to that country. So kudos to you guys. I mean, if anybody wants to learn about World Pediatrics, how do they learn about it, or just getting involved in that kind of work, as they get into practice, either as a therapist or as a surgeon?
Yeah, I would be neglectful if I didn't mention that we were supported in part by Touching Hands through the Hand Society. And so this was, Scott Cozen sort of ran with the concept of outreach as a part of the Hand Society's effort. And he with others, has elevated the outreach concept for the American Foundation for Surgery of the Hand as one of the major buckets. So there's a lot to learn from the Hand Society. And there's a lot of different organizations. We mentioned research, and there's many others aside from World Pediatrics doing this. But the Hand Study for those listeners is really a good one. And certainly I can connect anyone with of any background, whether that be hand therapy or general orthopedics, to people who are interested in doing this. But it's a great thing that we have the opportunity to do this, and it's not to suggest that we don't have enough opportunities in this country. The United States has plenty of need. This is just a little bit different.
Yeah, absolutely. I mean, you see that the Touching Hands program also has some domestic projects, and I think that many of us are also helping patients that are underserved and underinsured in our populations, and I think that's part of our professional obligation. So, before we get into some cases, first off, I want to say if anybody has questions for Chuck about that, handpodcast@gmail.com, send him an email, send us an email, and we'll make sure that he gets them. And y'all should mark your calendars for October 25 and 26 for Checkpoint Surgical's next cadaveric course, Upper Extremity Nerve Distress Strategies for Surgical Management. Join the course faculty, Dr. Fraser Leversedge and Dr. David Brogan. And we know those guys. In Denver, Colorado, is a review of management strategies for commonly encountered challenging nerve injuries and conditions affecting the upper extremities.
I'm glad you let me contribute to this. You left me a little bit. To learn more about this and other educational programs, please visit nervemaster.com. Checkpoint Surgical, driving innovation in nerve surgery.
So it's funny. I was driving home today. I was running. It's my daughter's. We're celebrating my daughter's birthday today with the school party. Her birthday was actually earlier this week, and that's a whole separate story of what we did. But I was driving home from picking up all the things for this party, and there's. I don't know if you've seen this, Chuck, but on Big Bend there's this recording studio that
I
has a sign
have.
out now for voiceover lessons. And I thought, I was like, hey, they often have like ads for like podcast recording, etc. I'm like, all right, we got that down. But I was like, maybe I should take some voiceover lessons, be the movie phone guy.
Yeah, look, you need a backup career plan, and that's a good one.
Well, I
You
was
might have
actually,
a future.
I was telling a patient this year or this week about my retirement plan, and I think it is going to go to culinary school. But maybe I'll be a voiceover guy. We'll see.
Yeah, so many options, so little time. All right, I think we have two cases we'd like to discuss. These are cases that we have, or pathologies we have not previously discussed. And why don't we start with a case that you had? So throw it out there.
Sure. So this is really interesting. It's a patient who I'm going to try to remove as many details as I can. In their 40s, a person who relies on their hands to make a living in terms of they're a proceduralist, and they've got this insidious onset of pain at their middle finger at the base, kind of proximal phalanx region. Was nagging, was getting, problematic, and then had some free time. So they decided to stop in and get a visit in one of our very convenient injury clinics. Uh, but got an x-ray, and I happened to be next door and demonstrated a lytic lesion within the base of the proximal phalanx, but no fracture. And findings were, to me at first blush, and the radiologist fortunately agreed, were consistent with an enchondroma. So, Chuck, how do you approach this patient? I mean, there was no actual trauma. It hurts. Not terrible, they had some time and they got it checked out. I mean, how do you think about these kinds of lesions within the bone?
Yeah, enchondromas are relatively classic looking. They can be expansile to the bone. They have that sort of ground glass appearance. Sometimes there's calcifications, but you can generally make the diagnosis on X-ray findings alone. They're often eccentric a bit. Um, and I think once you're confident in the diagnosis, then surgical intervention makes sense. I was taught, and I'm curious as to what you were taught. I was taught that if you have a fracture related to an enchondroma, which I know this patient did not have, but if you do have a fracture, I was taught to wait, let the fracture heal, and then go and do your surgery where you curettage and bone graft or plus minus bone graft. It's not how I think about it. I'm curious to how you think about the patient with the fracture and also what you did for this patient.
That's exactly how I was taught, probably because somebody like you taught me that. But so it's interesting because it's like if you have a fracture, you're supposed to let it heal and let it cool off, but then you go back and do something else. Like that doesn't make a lot of sense, but that is the teaching. This patient had pain, and because of the teaching, I said, "Look, you don't have a fracture. If you're cool with just watching this, why don't we just watch this? I'll get, therapists can make you a splint if you want, if you need support. But honestly, if you can tell me when this reaches a threshold where you're like, I need to do something." And that's initially what we talked about. How do you said you think about things differently than the textbook now? How do you think about it?
Yeah, for the reasons you said, it makes no sense to me to let a fracture heal and then do surgery. I do think these don't get, well, I should say that more clearly. These don't get better, right? They're not going to go away. And I sort of wonder why that became the teaching. And I think it's because if you think of pediatric lesions and you think of something like a unicameral bone cyst, if those fracture, they can disappear. An enchondroma with a fracture does not disappear. And so my philosophy is if you have a fracture, and honestly, even if you don't, certainly it's a patient-driven decision, but I encourage going ahead with the curettage and bone graft. And I bone graft most, but not all of these. Depends a little bit on the size. I have gone with either autograph from the distal radius or off the shelf. I don't have a strong opinion about that. I think the key is in the aggressive curettage.
You're taking away all the discussion points. I mean, you just really just blew right through that topic. You know, I had a discussion with the patient and we decided to keep an eye on it. But lo and behold, the patient, who I happen to know, contacted me and said, "Yeah, this actually really hurts. What can we do about it?" So I gave them the options that you discussed. I mean, so for those of you that may not be as knowledgeable about this topic just yet, I mean, so what this is a benign cartilage tumor. Tumor, not necessarily cancer, of course, but it's benign. The recurrence risk is there, but I think what Chuck talked about is that thorough curettage, meaning you're scraping out all of this stuff, this cartilage stuff that's sitting within the medullary canal of the bone. And as it kind of presses on the bone, it can, thin out the cortex and eventually lead to a fracture. So yeah, I mean, the teaching to me was, if it's painful, bothersome, they want to do something, you curettage it. So Chuck, how do you decide where to go into the bone to curettage it? Is this a big incision? Is it a small one? And then what's your magic technique for getting all of it out, like you talked about earlier?
Yeah, I think the approach is can be many. To me, it's whatever is simplest, and often that's dorsal through the extensor or adjacent to the extensor tendon, and often through the thinnest part of the lesion if it's expansile. So the thinnest part of the bone, I open it up. Classically for weight-bearing bones, we're taught to do that in a elliptical type fashion or a not a square kind of perforation of the bone. I don't know that it really matters here. And then I just think it's aggressive curettage. Whoever is with me is curetaging, I'm irrigating, and then plus minus packing with bone graft. What about you?
Similar. I think for this particular case, we were able to go adjacent to the extensor mechanism. And yeah, really is kind of aggressive curettage. So getting your curette in there and scraping all of it out, getting it from different angles. Um, how do you know when you're done?
You're done when you keep curetaging and all you're getting back is bone. At least that's my take.
And is it possible to push too hard and when you're curotaging and fracture that kind of thinner, weakened cortex?
For sure. Of course, it's never happened to me, but absolutely. Why did that
Yeah,
happen?
it didn't, but I thought about it as you were doing it, and it's one of those things like when you're harvesting distal radius cancellous autograft, the attending's got that extra move that gets tons of bone graft. I was like, if I'm gonna push hard, this is probably not the best situation to do it in.
Yeah, again, I think the morbidity is low. So you used autograft. Did you use autograft on this one?
Well, actually, I had a discussion with the patient. I mean, from the teaching that, I remember from training, and I actually went and looked up this topic again just to make sure nothing had changed because it's been a while since I've trained. There's no difference between using an allograft versus, so cadaver bone versus using somebody's own cancellous bone. So, with that in mind, and with this person who wanted to get back to using their hands and doing procedures as quickly as possible, we had a discussion, but honestly, I kind of steered her towards allograft, and that's what she picked too.
Yeah, I think that's great. Healing time is variable. And in my experience, it can be 6 to 10 weeks to really feel confident. But yeah, I think people get back to activities much sooner than that.
So when you pack this, after you've packed it with as much of the choice graft, how do you know when you're done? And then what do you do after?
Yeah, you pack it till you can't pack it anymore. Ideally, it's not spilling out, but you pack it nicely. Radiographs, mini C-arm look really great when you pack it nice and full. I tend to, in the OR, put a big bulky forearm-based splint, and then a week to 2 weeks later, have them go to clinic and get something really small and removable and start moving, so we don't worry about the stiffness piece.
So when do you think they're okay to start doing things with their hand in terms of light activities and beyond?
Yeah, obviously depends a little bit on how thin the cortices are. If it's a typical case where maybe there's mild thinning but not dramatic, I think they can obviously do the light activities essentially right away for heavy gripping or hitting the gym or playing a sport. I do think you have to be a little careful. So probably again, depending on the details, 6 weeks.
Right, right, right. So yeah, no, I think that's the balance is trying to figure out kind of what you will let them do and even little things about when you will let them sweat and shower and that kind of thing. I mean, so you went through this recently in the past with various surgeries. I mean, what's your threshold? And I actually asked this question when I was doing a case recently with our partner, David Bergen. I was like, hey, when do you let people start to let things get wet? And when do you let them start to sweat? So what's just backing out of this case, but like, what's your threshold for that?
Yeah, I think we've talked. I don't know if we have, but I've gotten really what I think is liberal. For most conditions, is 3 days. If I'm going to let them take off a splint or dressing, if I'm worried for whatever reason, is 5 to 7 days. As far as getting it wet, soaking it probably is fine at those same time intervals, but I generally ask them to wait until they see me at the first post-operative visit.
Do you feel different about getting it wet versus sweating? Of course,
No,
this person wants to run.
I don't feel different at all. I think the epidermis is sealed by 3 days. I think they're fine.
Okay. Yeah,
Eh,
so I've actually because of our my trip to Washington D.C. and switching my wound closure based on the advice of our colleague Sam Mogdateri, I've gone to 3 days for carpals triggers and anything that I close with subcuticular closure and dermabond.
Yeah, I love that. Oh, Dermabond, I go one day, but whole
One
nother
day.
one
Okay,
day,
all right.
one day. And then before we switch gears, and this is maybe for the residents or medical students, Alliier's disease, spelled Alliier's disease, is a really interesting condition associated with enchondromas. It's actually multiple enchondromatosis, and these can be very different players, much more aggressive. They require more significant and multiple bone procedures. And what's super interesting about this is it affects only one side of the body. That's the trivia there.
So there you go. There's your first aid for the boards from Chuck Goldfarb. So Alliés aside, how do you counsel patients with an isolated enchondroma about potential recurrence risk, et cetera?
Knock on wood, I haven't seen much. I tell them it's somewhere between 5 and 10% for a typical. If I feel like we've done a good job, which hopefully we have, for a phalangeal enchondroma, I say 5 to 10%. What is your number?
I basically say the same thing. I think I tell them it's low, but it's not zero. So I think I use that for a lot of things. If for the residents and fellows that have been in my clinic, because I think if you're the one, it's all that matters. So all right, well, that was a good discussion. Thank you for sharing your thoughts on that and bucking the textbook. Tell me about this case that you have as we kind of wind things up.
Yeah, this is something we haven't really touched on. I had a patient a couple months ago that I was taking to the operating room for a presumed foveal TFCC tear. And I had seen and treated him over a couple of months. I think I'd given him a steroid injection, which helped temporarily. Saw him back in clinic the last visit before. X-rays looked fine. Um, but not only did he have pain at the fovea, just volar to the ulnar styloid, he had tenderness over the pisiform. And over, by over, I mean directly volar, but also on the ulnar side of the pisiform. And so there are specialized x-rays one can obtain to rule out pisotrichoepithelial arthritis. I don't find those to be infallible, meaning I think people can have symptomatic pain at the pisotrichoepithelial joint even without obvious arthritis. Um, but it's an interesting diagnosis. And so, how do you think about pisotrichoepithelial pain plus minus arthritis?
Well, I mean, I think it certainly has to be in the differential. Basically every patient who I see with ulnar side of wrist pain, I will examine and palpate their pisiform and do a pisotrichoepithelial boost test. Essentially, you're trying to really provoke the pisiform against the triquetrum to see if you can get some pain going there. And that's a very distinct kind of pain. So it's certainly seen me. I've seen it a fair number of times, but it's probably seen me more than I've seen it. Honestly, after reading a few articles, I became much more attuned to the diagnosis and started looking for it more.
Yeah, I think we have to look for it because it's very easy to attribute that, especially if the pain's more vague to whatever on the ulnar side of the wrist. Um, the boost test or direct pressure, dorsally directed pressure on the pisiform or radially directed pressure on the pisiform. I also typically have them fire their FCU to see if that elicits any pain. Long story short is I didn't see evidence of arthritis by MRI or X-ray on this patient. Pain was absolutely consistent. And so I talked to the patient about the options, and my plan was at the time of arthroscopy, I confirmed there was a foveal TFC tear, so we repaired it. And one can sometimes scope the pisotrichoepithelial joint. And others talk about that. I think it's often a long run for a short slide, so it's not a huge part of what I do. In this case, I told him that if I didn't see any other reason for pisotrichoepithelial pain, that I would perform an open pisiformectomy, which felt a little aggressive.
Hmm.
Um, but in retrospect, it wasn't. And in this patient, there was probably 15 chondral loose bodies in the pisotrichoepithelial joint.
Wow, that's
Not
crazy.
visible but that's not really the point of this discussion. It's just be aware of the pisotrichoepithelial joint.
Yeah, no, when I see somebody who has who I think has pain because of pisotrichoepithelial synovitis arthritis, I will typically send them for an ultrasound guided steroid injection. Yes, I could do it in the office under fluoroscopy. To be very honest with you, it tends to be it kills workflow. So I send them for that injection, and that way I know it's exactly where it needs to be. It tends to be under ultrasound guidance, although depending on who's doing it, they may do it under fluoroscopy. Um, I like that. I've had to do a pisiformectomy on one patient for that reason, for this condition. But most people, I feel like, tend to get better with the steroid shot.
Absolutely. So well said. Steroid shots have the absolute role here. And if you do find yourself performing a pisiformectomy, there's two things that are maybe self-evident. One, there's a little nerve which is really close. Uh, so we
A
we took
critical nerve.
we took care of the ulnar nerve ester bundle, and the pisiform is bigger than expected every single time. It's bigger than expected. In this case, there was arthrosis, there were the chondral loose bodies, so we felt very good about it. And patients don't miss their pisiform, thankfully, and they tend to get better. Not always immediately, but they tend to get better.
What do you do with the FCU?
I repair it back to itself. Um, and it doesn't seem to it's not as if it loses its attachment. So I repair it back over the top and it still fires later.
Yeah, it's funny. Like you never really see the pisiform because it's always covered by the FCU, insertion. So I agree with you. Once you're taking it out, you're like, whoa, there's a As long as you get the nerve out of the way, you're okay.
You got to take care of the nerve first. So those nerve-centric people tell me. Um, awesome. What else you got?
You know what? I think we're at our point where we should wrap the case, but I think next podcast, we're going to dive into the latest edition of What's New in Hand Surgery, an article that I used to write, and I'm happy I don't anymore.
I know that is true. Well, I look forward to that conversation.
All right. Well, I got to go because I've got to head to a T-ball game.
Have fun.
All right. Take care.
Bye.